جميعا وكل عام وأنتم بخير. والله بسم الله الرحمن الرحيم، صلى الله وسلم وبارك على نبينا محمد وعلى آله وصحبه أجمعين. Very honored and pleased to be with you today again. We will go over some features of echocardiographic evaluation of RV to PA conduits. I will show you so many pictures and videos, and that's how the lecture will be. And during these lectures and videos, I will be talking about the issues in each video and picture. So causes of problems with RVOT and disease is so much variable. I mean, when we talk about disease, we talk about idiopathic, multifactorial, wide spectrum, incomplete penetration if it was a genetic, variable expression of a gene. So we truly don't know that much about disease. And if you know that, you really have to go back and use every tool you have, every information you have, every evidence you have to really come to the correct diagnosis, because the correct diagnosis, and more importantly, the correct understanding of what's going on, will make you a good physician to tell what is needed as treatment or what is not needed. وأحيانا what is not needed is more important. Sometimes we are in a difficult situation, a critical patient. Intervention may actually cost a lot of risk. And then you really need to know, should I do this or should I not do this? So to really know, you need to gather a lot of information. In diseases like pulmonary atresia, tetralogy, truncus arteriosus, we use different types of conduit. There are valved conduits, there are homografts, there are xenografts, and each one has its characteristics. So if you see a Contegra xenograft, we know that these conduits are notoriously known to have peripheral pulmonary stenosis even in the very early postoperative period. Why is that? Because the valve is really down towards the PAs, not towards the RVOT. And that gives the surgeon difficulty in how to anastomose the PAs. Usually the conduit is also bulky, and it may actually compress or cause tortuosity of the branch pulmonary arteries after surgery. The levels of obstruction when we have a conduit in place are multiple. You may have an obstruction at the RV to conduit, where the surgeon has made the incision and surgerized the conduit. At that area, you may find a stenosis. The stenosis is not only because of the conduit sutures, but sometimes it's because of incomplete cut of the RV wall muscle. Even if the surgeon left a millimeter or a half a millimeter, that may give an obstruction. And every obstruction, if you recognize what's going on, you can actually recognize what to do. So if I have an obstruction where the surgeon made the incision, and I think it's really below the incision by a millimeter or so, maybe just a short stent in that area will solve the whole problem. And the conduit will still be okay, and we don't need to change it, and we don't need to extend the stent down into the the valve, and then we actually destroyed the conduit. Is that clear? So sometimes it's not only different levels, but it's also multiple sequential levels of obstructions. So when we say different levels, we mean subconduit at the surgical anastomosis of the conduit to the branch to the RV, at the valve of the conduit, at the distal conduit where we would call it the confluence, or more distal at the branch PAs, one of them, or bilateral. Sometimes it's actually a combination. You may have multiple levels of sequential obstructions. So the most severe one will mask the others. So if the most severe one was the more proximal towards the RV, you may not appreciate any stenosis by color Doppler or by Doppler velocity, because the turbulence has started earlier. If the obstruction is distal, you may not appreciate the proximal stenosis because the flow will look like laminar, not because it is truly laminar, but because the distal obstruction makes the pressure before it high, and then it looks laminar. And this is a fault in Doppler. And we all know that this happens when we evaluate by Doppler color. And that's why any evaluation of an RV OT, pulmonary arteries, branch pulmonary arteries, is not just dependent on a color Doppler or a gradient, but it's dependent on so many factors. I can count 8 factors at least. Let's count them. It's dependent on the diameter. It's dependent on the color flow, turbulent or not. It's dependent on the amount of flow. Sometimes we see the amount very little. Sometimes the amount we see it actually good size of color Doppler. It's dependent on the gradient. It's dependent on the presence of pulmonary insufficiency. It's dependent on the RV function. It's dependent on the volume loading. Is this patient well volume loaded or volume depleted? It's dependent on the amount of tricuspid regurg. It's dependent on the presence of pulmonary hypertension or not. It's dependent on the presence of inotropic support or not. How about that? We counted 10 now. So before I do a study on echo to evaluate an RV to PA conduit, I really need to understand the patient situation. It's not just doing an echo. No, you have to go at bedside, examine the patient, know the history, know what the surgeon did, know that if the patient had pulmonary hypertension, know if the patient is hypotensive or not, know if the patient is well perfused or not. So whenever they call me to evaluate an obstruction, especially in the ICU, the first thing I do, I tell them, take away the echo machine. First thing, I examine the patient. Know all the confounding factors. Then I start doing the echo, guided by the information I gathered. That's why I said in the first slide, you really need to know your patient well when you are evaluating for an RV to PA conduit. RV function, whether it's systole or diastole. If you have systolic dysfunction, you will have less gradient. And that doesn't mean the obstruction is less. If you have diastolic dysfunction, the filling and the amount of blood being ejected to the PAs may be less. And then you are also deceived. Not only that, but your EDP is high. And then when you calculate the TR gradient, it may actually become 50, and you say, well, it's moderately obstructed, but the EDP is 20. So it's not 6 or 10. So if the EDP was 20, then you add it to the TR, you will find out that actually the RV pressure is almost systemic or suprasystemic. So RV function, both systolic and diastolic, is so important to know when you are evaluating an RV to PA conduit problem. Presence of TR, especially if it's trivial, then it doesn't affect the result. But if it is significant, then it can affect because of loss of cardiac output. But also TR is a gift. TR is important for us to have. And do you know why? Because TR is your way to know the RV pressure. And if you get a good envelope, you really know your RV pressure. Presence of an ASD is also important in evaluating a conduit, because if you see right to left shunt on an ASD and you actually get a low gradient, then how do you explain the right to left shunt? Well, it can be explained by many things. One of it is that you are actually underestimating the obstruction. The other thing is actually maybe there is diastolic dysfunction. Maybe the RV is severely hypertrophied. So many things can actually be figured out if you have an ASD. What if we are actually evaluating an ASD, an RV to PA conduit, which is regurgitant, not stenotic. And we want to see whether do we need to change that now or not. The presence of a significant ASD may actually give you a falsely high RV volume. And then you say, well, it's because of the PI. But maybe if you actually took care of the ASD, you will find actually that the patient is not yet qualified to get a new RV to PA conduit. And you know why is that important in pediatrics? Because we know that conduits in pediatrics are short-lived. If you put a conduit in a 5 or an 8-year-old, it won't be good by age 12. And then you need to put another one. So by age 18 or 20, you need to put a third one. That's not good. We need to time the best time to put a conduit, which to me, if let's say you did a truncus, and this truncus now is a 6-year-old with significant either stenosis or PR. And by MRI, the patient qualifies by RV volume index, PR percent, all qualifies for changing the conduit. Yes, I would change it, but maybe I wouldn't put a transcatheter valve. I'll put it surgically, because I know if I put a transcatheter valve in a 6-year-old who's about 18 or 20 kilo, which is possibly done, I know that by age 12, this valve is not going to be good. So instead of having metal and a second metal, put another conduit tissue and then come back when the patient is 12, 14-year-old, and you can do your transcatheter valve. Presence of a VSD is so much important when we evaluate conduits. If you have a big shunt and you have significant conduit dilatation, or you are seeing pulmonary hypertension or a TR that's high, maybe you should blame the VSD, not the conduit. Maybe the VSD is actually large, or the residual VSD, or the patch actually has the hyst, and that's important. Another importance of the VSD, if you saw right to left shunt on it, you know that the RV pressure in systole, I mean, right to left shunt in systole, you know that the RV pressure is actually systemic or suprasystemic, regardless of any gradient you get on the TR or on the conduit, you know that this RV is hypertensive. And if we know that the RV is hypertensive, that affects our management tremendously. We will have to go, maybe cath the patient, maybe do more evaluation till we know why is this RV hypertensive. Another importance of a presence of even a tiny small residual VSD is actually when it's left to right shunt. You know that the RV cannot be suprasystemic, maybe systemic or lower, but it's good to estimate the RV pressure because I know the patient's blood pressure, isn't it? If I know the VSD gradient, I can estimate immediately the RV pressure. Let's say we get a VSD gradient of 20 and the blood pressure on this patient is 120. What's the RV pressure? 100. So this RV, whatever gradient you get on TR or on PI or on the conduit itself, even if it reads 30 or 40, you know that it is not correct because you have a VSD gradient of 20 and you know you got a good envelope and you know your blood pressure. Branch pulmonary artery stenosis or PPS is quite important in the evaluation of conduits. And actually, it is quite important in the health of a conduit. Severe bilateral PPS may destroy your conduit valve early and cause a lot of PI early. Severe PPS, especially distally, may actually mask any gradient proximally. Severe distal PPS beyond your echo window may give you a severe high RV pressure without the conduit looking bad. I mean, you look at the conduit and you say, the conduit, wallahi, looks good. The valve of the conduit is moving fine. It doesn't look stenotic by 2D. The function is good. So why is the TR 80 or 90? Maybe you are dealing with distal PPS. Pulmonary hypertension works similarly like PPS. So if I have distal pulmonary hypertension, whether it's because of diffuse bilateral PPS or true primary pulmonary hypertension in association with congenital heart disease, or it is a high left-sided left ventricle end diastolic pressure causing it, then all of this may actually affect the way you evaluate your conduit. PI volume, a lot of pulmonary regurg may actually mask distal gradients. And above all, we all do mistakes when we evaluate. We may not take the best angle for the Doppler velocity. We may not take the best color gain when we do it. We may not take the best cut, the best angle, many errors. That's why perfecting your echo skill is so important. And I hope this lecture adds to all of us, to all our skills in really performing an echo in such diseases with RV to PA conduit. Right. So you see, you have to take in consideration all of these points. So welcome to the conduit world of uncertainty. That's why you really need, again and again, I'm going to say it, you really need to collect so much information to be able to evaluate and say, this is true. And by the way, remember this as a very important point. Any reading or any measurement or any flow or any Doppler that says that there is severe dysfunction, even if all the others say no, the conduit is okay, don't believe the others and believe the only one. Keep it in mind when you do that as an operator. So Is echocardiography a reliable tool for RV to PA conduit evaluation? Well, probably as in a general way, in an initial way, I would say yes, it is a reliable tool if we applied all the previous points I've mentioned, but it is not the only or the enough 100% tool to evaluate the RV to PA conduit. Keep that in mind. You may have to go to cardiac CT, cardiac MRI, or diagnostic heart cath to really know what's going on. So is it yes? Is it no? Is it yes and no? It is yes and no. As I said, in general, yes. Initially, yes. When it's complicated, it's no. When it's simple, straightforward conduit, it's yes. But when it's complicated, it's no. And we need further imaging to really evaluate the RV to PA conduit. So let's start by 2D echo. Now you will enjoy pictures, not talking. In this picture, what do we see? I mean, we see that there is probably a valve there. We see by 2D that the PA or the conduit here is of good size. We see the area immediately under is of good size, maybe slightly dilated, but it's not aneurysmal. The thickness is good. But what do we see here? We see two muscles where the VSD is actually almost touching each other. So this is a severe obstruction. You see the VSD here also, huh? So is this a patient pre-op or post-op? I won't tell you. We will just go to evaluate. So it's important from this picture to see the level of obstruction. See how it's actually, and post-surgical, you may be left with a muscle bundle very low in the RV, missed by the surgeon and not opened. And then you get at that level an obstruction. You can see here also, and maybe the RVOT is not moving that good. So function in this area is not good. So maybe this area was surgerized. Look at this conduit. We see the valve flickering. It looks like a valve that's not great. It's so thin, it's flickering. It's not opening and closing like a real valve, but it's just a flickering thing. So this valve, if I see this 2D image, I would probably guess that there is most likely significant PI from this valve. I don't think there is a stenosis, but look down in the conduit. See, there is like an hourglass area there. And maybe this area is actually obstructed. So, but just by looking at the 2D and giving yourself some time, you will see that this area is an hourglass and it's less diameter than the area above it. So why is the valve now doing that? Now we know why. Because of distal obstruction, high pressure in the pre-obstruction area, this valve got destroyed. That's why when you have a new conduit and you detect distal obstruction, significant, severe, moderate to severe, or severe, that obstruction need to be relieved immediately. Otherwise, you know you are going to lose your valve of that conduit. Here also, the branch pulmonary artery is not bad. Looks like the left is better than the right in this patient. I think this is the information we can get from this video. Let's look at the other one. So in this video, what is the most striking finding? I think the most striking finding is that a very narrow RVOT below. And also look at how this conduit became so cylindrical and small. So this conduit actually shrunk. And we do see that in conduits in children. They shrink because of being attacked by the immune system, they fibrose, they shrink. That's a bad early sign if you see it, because you know that this conduit is going to get obstructed very soon. So look at this area, tight. The whole area is actually more like a cylindrical. The branch PAs, maybe there is a stenosis there. See, again and again, 2D. Luckily enough, this RV function doesn't look bad. The tricuspid valve is opening, not prolapsing. The whatever RA we are seeing doesn't look significantly dilated. So what about this conduit? You see, this is LV, this is RV dilated, more like an aneurysm. What happened to this conduit? What did they do here? So this is the conduit with a stent. That's the valve moving good. And the stent is actually in the usual area we see the obstruction at, which is just distal before the branches, like where you would call it the confluence of the pulmonary artery. Sometimes we are lucky, we can deploy the stent just before the PAs and not cause any obstruction and relieve the obstruction within that area. In this stent, if you just look at it clearly, the valve looks moving not bad. Uh, I cannot see the distal stent. Maybe it's obstructed, but for sure here it's wide open. Again, in evaluating a conduit, it's not just the conduit. It's very importantly the right ventricle. What do you think about this right ventricle? Severely hypertrophied. Cavities obliterated by muscle. Function is not great. So what about this RV? Is it facing a major obstruction distally at the conduit? Is this RV actually, to start with, severely hypertrophied and maybe somewhat small? If I see this kind of RV, I wouldn't care about whatever I see distally if I got a high pressure or the patient is not doing well and showing signs of right-sided failure, because I know that this RV is sick. And for the sickness of this RV, there is a cause. And if there was a conduit, then most likely there is an issue with the conduit, whether the area below it, the conduit itself, the distal conduit, or PPS. Sorry. Okay. So again, a conduit looking nice, nice moving valve. And look at how the under area is good. The LPA looks wide patent. What do we see here? It's a stent in the RPA. And why was it put? And I think it's the same patient I showed you before, where the RPA was slightly small. See how now relieving the obstruction and keeping a good flow makes this valve moves properly, opens properly, and closes properly. What's happening here in this RV? It's slightly hypertrophied, but it's dilated. So this is an indication where probably the conduit here is actually regurgitant more than stenotic, or this patient has significant TR or an additional ASD. So you see, just by looking at a 2D image and trying to figure out why this patient with an RV conduit will have a dilated, slightly hypertrophied RV. So maybe there's an element of obstruction, but more element of pulmonary insufficiency or regurgitation. Look at this conduit evaluation, and that I'm going to show you a lot of 2D just to confirm with you that 2D is so important. This conduit shows one of the valves working well, the other is not working well. So if I see this and I know this from the start and there is PI, I know it's because of a malfunction of the conduit itself. Sometimes it is because how the surgeon has put it, it got twisted, it got involved in a suture, whatever, or just this is how the valve was. And also here, look again, the distal area is not great. The PAs are underfilled. So here you may have more than one problem of this conduit. A valve that's not moving well and actually it's thickened while the other one is thin. So maybe it is inflamed. I wouldn't say endocarditis, but maybe it's inflamed immune-wise, like the body doesn't want it, wants to reject it. And again, you see how the stenosis here and the smallish branch PAs because of the limited flow, or maybe they were also small to start with. This is a valve that's working reasonably okay, but here you see we don't see well the confluence or the branch PA. So we really have a major problem here in this patient with distal PPS most likely. This is again a hypertrophied RV. LV function is good, dilated, but more hypertrophied. So expectation here that you have a more obstruction disease in the conduit rather than a non-obstruction. This is a good demonstration of how the conduit towards the RV is actually dilated and the valve is not bad, although it's flickering. But why did this conduit dilate and the RV OT itself dilated? Because of severe bilateral PPS. And actually, you can see that there is already a stent in the LPA. So this is probably a fresh post-op who came out with high RV pressure, and it was noted that he has bilateral PPS. And to save the valve, keep this valve opening and closing, and not to have severe PI, this stent was put. The RPA was left, although it's not free of disease completely. Same picture. And what do you think about this one? I'm sure many of you will say this RV is or has a suprasystemic pressure just by the nature of knowing how the interventricular septum is actually going inside the RV. Is almost squashing, not terribly squashing the LV, but it is, and dilated. If you just see this, you know you have a major problem with this conduit, and you have to evaluate it from A to Z to really know what's going on. Where is the obstruction? This is an interesting case where actually there is like a tear in the interventricular septum, and then a conduit. So some may call it an intramural VSD. I'm not good at really evaluating that. But you see, sometimes you discover in patients with conduit that they have an additional VSD or a residual VSD. And you can see here actually how the conduit itself, the area where the conduit is being fed is stenotic. The whole conduit, again, having that cylindrical look to it or structure. And when we see that, we know that these conduits are going to obstruct quite fast. Again, a conduit, but the pictures are not good, so I'm going to skip this. Also skip this one. See here, a very important finding. We see the valve flickering. We don't see distally quite well, and that's a problem. And that could be just a limitation, because sometimes the branch pulmonary arteries are actually diving anteroposteriorly. So when you put your echo on the uh, chest of the patient, you're actually looking downward. You cannot go up or left. And by the way, a lot of the conduits, when you want to really to evaluate him, try to go a lot to the left and slightly up near the clavicle. You may get the conduit. So this is a patient with an aneurysm in the RVOT, starting aneurysm, and a possible severe obstruction distally. Same patient probably, but a better picture. Again, you see here, we don't see the branch PA as well. Maybe it's just the cut. Maybe it's an error by the operator. Maybe it's just the angle, and the conduit is fine. But here, we do see a dilatation before, and maybe it is actually truly obstructed. A conduit again obstructed, the valve is destroyed. There is already a stent in the left side. We don't see the right side. Stents and their struts may actually mask flow or mask the other PA. So you really have to look at different areas and different angles. You may actually go in the suprasternal, transverse, and look under the arch to see the RPA in this kind of patient. And then you will be assured, is the RPA size good? Does it have good flow, or it doesn't? And maybe the stent actually is obstructing the RPA origin. But we can see that actually this conduit is coming to be changed soon, because the valve is already destroyed. Whether it's destroyed by the stent, it's unlikely. It's probably destroyed because there was long-standing peripheral PPS that was left untreated. Here you can see an obstructed, but the stent actually was put too long in the PA, and it affected the valve, and that's actually a problem in destroying conduits. You may have a good conduit, but with a bad intervention, this patient will end up, see, this valve is involved in that stent, and this valve conduit will actually keep regurgitant. You lost the conduit function because of treating PPS. Sometimes it's difficult. Sometimes you just have to, because the surgeon will not take him. His surgery was just done recent, and there is severe obstruction, and you are either going to put a good stent to make a good flow to the PAs, and the baby is small. This stent is probably a coronary stent. So I would expect that this baby was probably a truncus arteriosus who was stented, and there was small PAs, 3mm, 4mm, where you cannot even put a 7 or an 8 good stent. And just to save the patient RV and life, a stent was put to just to keep a cardiac output and flow. Although it ended up, you see, destroying the conduit valve. And see how much important is 2D to give you the cause of destruction of the conduit. Now we know if this patient comes later on, I know that PI started very early, and I know that we just bought time, and we know that we're going to change this conduit very soon. A patient with two stents crossing each other. See, there's one in the RPA, one in the LPA, and a lot of the time you will see that when you do especially angios or CT, that the conduits PAs are almost crossing each other, because the conduit has twisted it when it was put in the chest. And you may think that these stents are obstructing each other, but they may not be, and you really have to take different angles, different views to prove the good flow in the left and the good flow on the right. Right. We said RV function. See, this RV is dilated, is hypertrophied, septum is bowing occasionally to the LV. Function is fair to good. So if I get to see this RV, I will somewhat trust my gradients, my TR gradient, my RV to PA gradient. I will trust the number. Unlike if I found that this RV is not functioning well. Similarly, like how we will evaluate patients with pulmonary hypertension. With pulmonary hypertension, if the function is good, you trust. If the function is bad, you don't, because you know that you are underestimating because of poor function. This kind of ends up our 2D part of the talk. We are left with color, and then we are left with Doppler velocities. I see in the chat when we start at 10 minutes. Salam alaikum. طيب. Okay, so nothing there. Any questions here? Any comments before we move to color Doppler? معايا ولا نمتوا؟ Anybody around؟
طبعا حضرتك.
طيب في أي أسئلة في أي شيء؟
يعني ممتعة جدا ما شاء الله. يعني عندما يكون
مو مشكلة
البيدياتريك
ممتعة،
كارديولوجي
بس
ممتع
في
ما شاء
أسئلة،
الله.
في تعليقات قبل ما أنقل ولا أنقل؟
طب يا جماعة في أسئلة؟
طيب. So let's move now to color Doppler, and we saw the 2D part. Now we'll see the color Doppler. Luckily enough, this patient has good color Doppler. We don't see here much turbulent blue flow. Forward flow seems to be okay in both branch PAs, not bad. But we see that we started to have PI. The one message from this echo is that the PI is actually coming even from the branch PAs. This has two implications. Either it is just severe or free PI, and that's why the flow is reversed even in the branch PAs, or it may mean you have distal PPS not being discovered by this echo image or echo view. And that's why in this patient, you need to guarantee what is your RV pressure. You need to go back to the TR and take actually the PI gradient to just comfort yourself that they are low, and this is only severe or free PI, not distal PPFs. So color adds to you the size, as that diameter by 2D is important, but also diameter by color is important. No one will say that this is an obstructed conduit by 2D or color. You may say that this area still looks small and there is some turbulence, but it doesn't look terrible or bad. You may say that the branch PAs are not of the best size. They are maybe smallish or moderately small, but they look acceptable. So in this patient, if I have RV hypertension or RV failure, in spite of this good conduit, what would I tell the surgeon? Go and change the conduit? Well, maybe it is because of the PI, but how many patients we see with PI that are actually not symptomatic? Most of them are asymptomatic, especially in the early childhood and adolescent age. So what I would say, maybe actually I need to evaluate more before saying anything that needs conduit change. Maybe I'm missing an ASD. Maybe I am missing distal pulmonary hypertension, which if I treat either the ASD or the distal pulmonary hypertension, or maybe there is LV diastolic dysfunction causing elevation of the RV pressure, not because of the conduit, but because of secondary pulmonary hypertension. And then if I give good afterload reduction, control, maybe diuretics, maybe there is significant aortopulmonary collaterals. Don't forget that. Aortopulmonary collaterals may actually show you reversal of flow in the PAs because of the tremendous flow. And they may actually give you a high pressure in the RV. All these things have to be thought about. In this conduit especially. Why? Because this conduit looks great. I mean, this is, if I see this conduit, I wouldn't be in a hurry to do anything. Maybe the PI needs something, yes, but it is not something that has to be done right away. So you see how much information we can get just by looking and analyzing, really analyzing, thinking a lot about the picture we see. You can get a lot of information. Look at this dysfunctional RV, see? And I mean, there is here what looks like maybe a fistula, maybe, I don't think it's a residual VSD, but maybe it's actually severe mid cavity or area under the conduit with severe obstruction. If you see this sign, it's not great. Luckily enough, there is not much TR, and it's unluckily enough there is no TR, not much TR. It's hard really to get the pressure, but there is on 2D severe RVH, dysfunctional RV. See, this area is the only area moving. This area is not doing much, and there is this tiny turbulent flow. It may be actually the tiny area where blood has to pass through to the conduit. And keep that in mind. Very proximal obstruction is very important to evaluate when you are doing conduit evaluation. This is a nice conduit with mild plus, maybe mild to moderate PI, very laminar flow. We don't see the branch PAs, but looks like a good conduit. The area above is not that dilated. Function seems to be good. So this is kind of a relaxing conduit, but there is a stent there most likely. You can see if there was really a stent there somewhere in the LPA or the distal conduit, it really saved the conduit. So you have to get used to seeing stents and struts of stents and how to evaluate the flow through the stents and so on. This PI is important to use. Whether it's a conduit or any echo you do, if you see PI, please take the gradient of the PI. It will tell you about the diastolic pressure and the mean pressure in the area above it, which is the PAs. And that's quite important for us when you evaluate conduits for PPS and for presence of pulmonary hypertension. This is a conduit which seems to be functioning well. Mild PI, maybe mild plus. Bilateral branch PA stenting. Stent looks good. They are not crossing each other. They're stopping just at the orifice. The right pulmonary artery seems to be larger. The left seems to be patent, but universally small throughout. There is turbulence on both, but looks like a good conduit with that needed to be treated with stent for PPS. It's important when you see this turbulence and you see how the area above is very laminar, because as we said, that the most distal controls the most proximal. Here you won't see any turbulence because this pressure here is high, and the only difference in pressure comes from here and distally to the lung. And if I see this by color Doppler, I have to do velocities and whether it's by pulse or continuous to really delineate and really know, is the flow through the stent acceptable? It looks by color acceptable, especially on the right side. Maybe the left side, there is quite a narrow area there where the turbulence start, and I really want to know what's going on. I may need to do actually flow studies, like you may have to do a lung perfusion scan to see what's going on, or a cardiac MRI with a perfusion calculation, just because of this appearance where actually, see how the LPA proximally is still quite blue. Just mid or in the first third of the stent, there is actually the turbulence start and it looks really small. So maybe this is in-stent stenosis, and you really need to evaluate it by multimodality, not just by color, not just by uh, by um, by Doppler, but also you need to know the amount of flow. Very important. We deal with children. If we keep a stenosis in one lung, which is important, but the distal lung is good, that lung will will with time become hypoplastic. It's not well supplied. It will not grow properly. And we need our patients' lungs to grow properly. So you see how important just color Doppler and paying attention to each detail. If I take the PI here, it will be high PI. Why? Because the pressure here is high. And it's a good indication of how good are these two stents functioning or not. This is a conduit with a left pulmonary artery stent. You see that this pulmonary artery is actually small throughout. But where is the obstruction truly? Is it really at the PI or at the distal conduit? I can tell you from this, where the turbulence start is actually the distal conduit. It's not at the valve because the PI stops here. That's where the valve is. And you have your PI. The other thing, note how much is this PI actually turbulent. So this PI is going back to the RV with high pressure. When you see turbulent PI, you have to conclude that this is actually a high pressure TR. It's quite an important sign that maybe this is good flow, but you do have a significant obstruction here distally, and it has to be dealt with. تفضل. Okay. See, here it's measured 5 millimeter. So measuring branch pulmonary arteries by color Doppler is good. Sometimes you cannot do it by 2D. But if this is 5, this is maximum 10, maximum maybe 8. 8 is something for a neonate. So we know just by taking this measurement that this area is actually also small. What's going on in this patient? What's the most striking thing in this patient? All right, let's go from up down or from proximal to distal. Below here it looks fine. The valve is thin, moving, closing. The PI is not much. The confluence seems to be okay, but significant LPA stenosis, possibly stented also or not, I'm not sure. But what is very striking here, we don't see the RPA. So we don't see the RPA. Is this RPA occluded, or is it just the angle and we have to look for it? So look for it in everywhere, from subcostal, parasternal to the left, modified view, and just below the clavicle, from the suprasternal under the arch. Look for that RPA carefully, because if you really don't see it, you need to move quickly before you lose that lung forever. Maybe the obstruction happened recently and you really need to tackle this area quickly. You may want to do a CT or just take this patient to the cath lab to tell about this RPA and then manage it accordingly, whether interventionally or surgically. So what's striking here is really we don't see the RPA. Well, RPA is actually there. This is the same patient, but we had to do a different angle. And you can see that they are both, they were both stented and they are both small. So now I can rest assured. This is the result that we got. I don't think we can get a better result because they all look small throughout. The LPA looks small throughout. The RPA looks small. The function of this conduit is good. Even if the RV pressure here is slightly high or moderately high, I actually may accept this result until I get the most time I can take from this conduit without losing RV function, and then go to change or to intervene more on the branch pulmonary arteries. So it was here an issue of angle and different area to see the RPA. Look at this patient with a conduit. Leave the RV alone, but how about LV function? It's not great. The septum is dyskinetic completely. RV actually is not bad. The free wall is not bad. So here you may actually find the TR high, but because of an LV dysfunction, not because of conduit obstruction, PPS, or pulmonary hypertension. The TR here is only mild. It's important to trace TR quite well so you can really evaluate your patient and know the pressures. See, this is actually the reverse of the previous picture. Look at how this was the previous picture. Here the LV looks more dilated and the RV less. And look at this one. The LV is suffering, being compressed. The RV function is not good at all. The TR is mild to moderate. And if you get a gradient here, will you say it is good or overestimated or underestimated? For sure, you will say it's underestimated. Just looking at this RV, if I see any obstruction in the conduit, I will call it severe immediately without looking at gradients or sizes or anything, unless there is severe pulmonary hypertension or dysfunction was lost because of a coronary issue, or it is an immediate post-pump problem. Again, the usual in contegras, especially, see the dilatation. This is the patient we showed the 2D of, and see where the obstruction really comes. Just at the confluence, there is a small LPA. The RPA seems to be acceptable. This patient obstruction, just by looking at this 2D picture, if this is the valve diameter, maybe this was let's say a 14. I mean, here we have this is from here to here is 2 centimeter. So it's about 8. Yeah, this is about 2 centimeter. So 20. This is looks like an 18 from here to here. This looks more like a 10 or an 8. 50% reduction of the diameter or the annulus of this valve conduit. That's a severe obstruction. Just looking at it, the severe turbulence, the minimal flow to the LPA, and the dilatation in the area proximal to the conduit, that this is a significant obstruction. Conduits can be put from very low in the RV. Sometimes the surgeon will find actually a coronary, or the area is difficult. They will go to the lateral wall down in the RV and put the conduit. This is an example where the conduit is actually down in the RV on the lateral wall. It's okay. You may miss and you may not see it at all, but it's a great conduit, not obstructed, mild PI, good flow. So remember, conduits are not always put in the RVOT or in the area below. Sometimes they're below because of coronaries, because of other issues, and you may actually have to pull down your echo probe there to see the conduit. And color helps you a lot in this odd situations where you really don't know how to get that conduit. This is a conduit with good flow. This is an eccentric PI from this conduit. Doesn't matter, but it's just an eccentric PI. You can see how it's actually expansile. So this conduit is large. There is not significant PI. The branch PAs are a bit dilated. Can you figure out what could be the original diagnosis of this patient? Seeing the expansility of the branch pulmonary arteries? Maybe it was a TET absent valve. Maybe. The branches are not dilated, but you see how they expand suddenly and go back, expand suddenly and you go back. Maybe it was a TET absent valve where a conduit was put. Again here, the very important sign of a turbulent, high velocity PI because of distal conduit obstruction. Look at what is passing through this conduit. This area is obstructed, only a trickle of flow. So this conduit, just before it goes to the branches, is severely obstructed. Just looking at the Doppler color, you don't need to do anything else. That's why I told you in the start, one abnormal finding, severely abnormal finding, is enough to say that there is a severe abnormality or severe problem with this conduit. Here you see the severe PI, and here you see the minimal flow going through, and it's not turbulent. You may ask me, why is it not turbulent? When this is the obstruction, anything distally to it should be turbulent. I'll tell you it is not turbulent because the flow that's passing is extremely diminuted, extremely low. There is not much to cause a turbulence even. It's just trickling. بينقط. ما فيش. تمام? Again, the same patient. And you can see how actually the flow is in the branch pulmonary arteries is so much, even I can say almost totally obstructed. Almost. I don't see any flow going in. It looks just like a, like a chair without cut in the middle. See, you can actually tell from this 2D patient, this patient is sick. Probably this patient is on oscillator ventilation. See how the whole image is vibrating? This is an eccentric TR. When you see an eccentric TR, it's very difficult because you really cannot align with it and you don't know how to get a gradient. It may actually look like a VSD, but it's actually an eccentric TR. It may be truly a Garbudi defect, and actually it will give you a high gradient, but the RV pressure truly is not high pressure. So when you see an eccentric TR in evaluating a conduit, make sure it is not a Garbudi defect from a VSD, and make sure you can align in the best alignment with your angle to get the true gradient. And look at this. So it's a truly a VSD. I think it may be the same patient. And what we were seeing there, what looked like a very eccentric TR, maybe actually is part of this VSD. You can see that this VSD is shunting bidirectional, left, right, and left, right. There is actually more than a hole in this patch, one here, one there, and some distance there. So this RV pressure, when you see the hypertrophy function is not that bad, fair to good, but this VSD tells you immediately that the RV pressure here is most likely high. Again, the VSD here, turbulent, mostly left to right, occasionally right to left. Again, pointing out that this RV pressure is probably not suprasystemic, but you see the blue is in diastole. The blue shunt, or the right to left, is actually in diastole. So there is probably significant elevation of this right ventricle end diastolic pressure. Another conduit that looks quite good, not much of turbulence, becoming cylindrical again, especially down there. You see, the problem with this view, you cannot tell about the branch PAs. Why? Maybe the operator did not use enough color gain. They have to increase the color gain to really see the branch PAs. Maybe the scale is quite high, and if there is no obstruction, and this is a baby, maybe this scale needs to go down more like 70 to be able to see, because we see on 2D that there is probably good branch PAs. So why are we not seeing good color? Unlikely obstruction, more likely the color gain here is not enough, and maybe the scale needs to go slightly below 90 to be able to evaluate those branch PAs. Sorry. A good conduit, except that the RPA is looking small. This RPA, regardless of the gradient I would get, if I get a gradient of 20, I will not call it mild PPS. If I don't get any gradient, I will not call it no PPS. If I get a high gradient, it just confirms what I know before the gradient. This RPA diameter by color is extremely small. So this is a severe RPA obstruction, unless it's a severe RPA hyperplasia to start with, and we know that. But here, I would go and get more evaluation of that RPA to really assure myself. You see how the LPA flow is good, and the LPA size is actually good. Evaluating a conduit from its start by color seems to be okay. Mild turbulence, we don't see the distal because we are not really concentrating here. We are concentrating more. Should this operator had brought the triangle of the color, the sector of the color more here? I would say yes, because I don't like this area here. It looks more narrow. And although I don't see turbulence, which probably means it's probably okay, but I would want to bring the sector there and actually more evaluate also here and down. So this is where, you know, the operator may actually have errors and say, well, it looks good flow. Khalas, alhamdulillah, let's move to the next picture. No, I'm sorry. This is not, the technique here is at fault. The technique here is not great. Subcostal view is very good in evaluating the subconduit area and the whole conduit. And you can see here, turbulence starts below, and the whole conduit is actually cylindrical and small. Alhamdulillah, good RV function with possibly a conduit which is very narrow. So don't forget about subcostal in a valve. It's like when we do subcostal for pulmonary valve stenosis. Sometimes it gives you the best gradient, the best image to evaluate the sub area and the valve and the supra area. Look at this conduit, blue, red, blue, red, blue, red, blue, red, dilated area below. So this conduit is probably not moving any flow. And whether this conduit is not moving the flow because of PPS, you can see the stent here on fast. And the flow in this stent, if I see it, it's coming to me like that. It seems to be not bad if this is the diameter inside, but I don't see the RPA. This just tells you you need more angulations and different areas of views to see this, the branch PAs. And then you have to figure out, why is this conduit swirling of this blood? Is it because of distal PPFs, or it is actually just a severely dilated area where the blood is inefficiently being pumped into a low resistant dilated area and just goes swirling, and by that you are losing cardiac output and the patient is not doing well. So this is an indication to must reduce this area to have good flow. يعني الاريا here is acting like a capacitant زي المخزنات الطاقة. It just absorbs the ejection of the RV, but doesn't let it go as forward flow to the branch PAs. But before we say that, we really have to evaluate these branch PAs in better angulations and better views. See how this RPA, there is a conduit, there is a stent that has mid obstruction that needs to be dealt with. This RPA probably is diffusely small. So again, regardless of gradient, regardless of anything, we know that this RPA is not good, and this area is not good in the conduit. Not only that, you can see how the PI is being reversed through the RPA. So maybe we have more distal obstruction here that needs to be evaluated with other modalities, because echo cannot go that deep. LPA, we saw this image in the 2D. You see, LPA stent needs to be evaluated in a different view. Now the operator changed, and you see how the LPA stent is actually good flow. It's even better than the LPA, but both have reversal of flow PI. So distal hypertension, distal PPS, more distal than this area, presence of pulmonary collaterals, all of these need to be evaluated. But the important thing here is that you really have to angulate in many different ways, try different areas in the chest to be able to say that the stent is flowing, or there's flow or no flow in it. Because if you don't, you may tell the surgeon, if we go back here, well, it looks like obstructed. It needs to be changed. No, do your angulations, and actually you may see, and maybe this is the best result you have, and you, after doing more evaluations, that there is nothing much can be done distally, then you will accept it. But how did you really know that? Is by doing a detailed echo, different views. Remember, conduits, you have to do different views, not regular views. You may have to go different, right, left, up, down, till you really align yourself well with the area that you are evaluating, and then you get it right. And here in this view, they got both flows, showing that they are both at least patent, with not much turbulence, probably indicating distal PPS there, or pulmonary hypertension, or collaterals, as I said before. This LV is happy. This RV's function is not bad, moderately dilated. But what are we seeing here? What's really not happy? What is not happy here in this conduit evaluation of this patient is actually the RA. The RA is the most sick chamber. See how the interatrial septum is going to the flow from the pulmonary veins is excellent, is good. So cardiac output is good. So why is this RA so dilated? The TR is not bad. So maybe there is significant diastolic dysfunction that's being missed, or the PI from the conduit is just too much, and the volume load on this right ventricle from the PI is severe enough to cause diastolic dysfunction. This is a kind of a late case, huh? So remember, even the RA can give you a lot of information. Subcostal view, the obstruction here is just below. Doesn't look bad. The diameter of the color looks good, not much PI, but there is some obstruction. Mind you, the function here is not the best, but it is fair. So if I would look at this, say, and I would say, what would I expect from this conduit just below, area below the conduit? Severe obstruction, mild or moderate? I would say probably mild to moderate. And I will be, just by looking at the color, I am more assured because of the diameter, because of not much PI. So here we stop color, and then we'll go to the final part of this lecture, and we'll do the Doppler velocities. So this is somebody trying to get an LPA gradient by pulse Doppler. Is this good? Would we say that maybe the gradient is about 2.2 meters per second? So 4 times 4 is 16. It's not bad. It's mild. No, I would say this is a poor pulse, poor Doppler. Because why is it poor? Because of the aliasing. You see, there's aliasing here. So this is not good. You cannot do that. Now you are forced to use continuous Doppler, not pulse Doppler. Again, on the right side, the same thing. See, this is a nice pulse Doppler in the RPA, and you can see that there is very good envelope, no aliasing, and the slight PI signal or slight reversal of flow in the PA. This is assuring. This is a good envelope, very assuring. As I said before, try to use your VSDs, your PI to estimate pressure. This is not TR. We are in the RV. in the near the AV valve or near the perimembranous area, and we are using continuous Doppler, and look at what we get. We get positive flow. That means it's going down to the apex of this RV, and the gradient is almost 70 to 75. So indicating that most likely this RV pressure is low, and most likely this is a VSD, not the TR. This is a pulse Doppler showing that actually the forward flow is not great. Huh? It's less than 0.5 per second. Sorry, meter per second. Yes, um, and actually the PI is 2. So here the forward flow or the cardiac output is not great. Either it's because of the severe PI. This is not severe by gradient, but it is severe by probably amount and percent, or maybe the function of this RV is not good, and that's why we are really not getting a good ejection. And in spite of seeing the valve opening and closure, but we're not getting good flow. So is it RV pressure not great, RV function not great? Is it cardiac output which is low for any different reason? And you can see the PI is a better, or is it just because of severe free PI? This is in the distal part, and it's not a bad Doppler. It's a pulse Doppler. It's not aliasing. The message here, would you take the gradient down here or where the envelope has developed? I would take it where the envelope has developed. That's why we took it here. And this is not a significant obstruction. Again, continuous Doppler in a conduit showing the PI, showing the mild obstruction distally. You can see 2 envelopes. This larger envelope is because of the obstruction here, and this is the velocity across the valve. Even with pulse Doppler, we confirmed that this is still a mild obstruction, and we're not picking up any obstruction distally, because when you use continuous, you don't know really, is it at this area or distal or before? But if you got a good envelope by continuous Doppler, then it's quite reliable. This is a continuous Doppler towards the LPA. It's taking the whole area. We know this area is good. We know this is quite dilated, so probably significant distal obstruction. And actually, this is what this envelope is giving you. It's about 4.5, so it's at least 70. So there is severe, most likely severe LPA or bilateral PPFs in this patient. Very reliable, nice envelope, complete, and that's what you really want to see. You want to see such a nice, reliable, complete envelope. This is the TR of almost the same patient, and it's giving you almost the same gradient. So that's good, because both are now trusting or confirming each other. So RV pressure, and it gives you actually an additional information that most likely the diastolic function of this RV is still very good. Probably the end diastolic pressure is around 5 or 6, because the TR is almost equal to the conduit obstruction gradient. This is more PI, less obstruction. The same, as I told you before, it looks turbulent, but the diameter looks good. So I wouldn't be expecting severe obstruction. And here, the velocity Doppler gives you the same findings. So that's what I was talking about. You have to build up the evidence, build up the information, add them up, then conclude. So when we said that this is not a bad obstruction by color and diameter, but there is turbulence, the Doppler velocity came and confirmed to us that actually you are right. It is not a significant obstruction. Again, no significant obstruction, but significant PI. And this is the one with the turbulent. At the valve, there is no obstruction. It's a continuous flow, but the PI is significant. So are we dealing with PPS more, or are we dealing with some elevation of the PA pressure? Not severe, but it is elevated. You can see here, probably, well, I wouldn't say really elevated. It's almost 2.246. So around 3 times 3 times 4, it's around 30. So you may have starting pulmonary hypertension in this patient, either because of PPS or distal, because your mean here is around uh, 25, maybe towards 30, and that's mild uh, or starting pulmonary hypertension. Again here, this is by pulse Doppler. I would accept it. It's slightly aliasing, but in this case, I will confirm it with a continuous Doppler because it starts to want to aliase, but not a bad pulse Doppler signal. And again, it confirms by 2D and by color that the area is wide. This is towards the RPA, good envelope, no stenosis. So having said all of that, this is my final slide for this talk today. أسأل الله سبحانه وتعالى أن يكون يعني علم ينتفع به وخالص لوجهه الكريم. So tips for better conduit evaluation. Plenty of 2D. Really know your conduit structure, shape, diameter, how the branch PAs are oriented. Are they crossing each other? Are they in a different area? A lot of 2D until you visualize in your mind how does this conduit look before we say how is it passing the flow or not passing the flow. Estimate RV pressure through more than one area gradient, through the TR, through the VSD, through the RV to PA, and through the PI. The best, if they all agree together, then you know your result is 100%. If two of them agree together, then your result is very good. But if they start to contradict each other, then you know you will need further evaluation with another modality. You may actually have to go in with a diagnostic cath to estimate the pressure correctly. Color Doppler levels or levels of turbulence. Just by looking at the color Doppler, you can tell where is the obstruction, how bad it is, how much flow is going through. That's a lot of information. So after you have done a lot of 2D, do a lot of color and pay attention to all the areas, the pre, the at, the post, the PPS, the TR, the PI, the VSD flow, the ASD, till you are really sure of what you have. Supplement eventually your evaluation with cardiac MRI, cardiac CT, or heart cath to really reach the final diagnosis in a patient who you think is not doing well, or who you think that the conduit has not been evaluated quite well by echocardiography. Take in account confounding factors like we said before: poor RV function, severe TR, severe PI, decreased preload, pulmonary hypertension, tachycardia, anatropes, and so on. take the highest reliable RV to PA gradient. Let's say you are doing an RV to PA gradient, you got many numbers of 40, 45, and one number was 80, and it was a good number, good envelope, but you got it once. Believe that once as important. As I always said, when you are evaluating right-sided obstruction, one figure out of the 10 or the 12 we mentioned says it's bad, believe it's bad, and evaluate more. You'll be surprised that this is actually the most true figure. Thank you very much for your audience, your presence. Sorry for the long presentation. I hope I presented you something that's useful to your daily life and work and to your knowledge. Thank you.
Thank you.
شكرا يا بروف، تسلم ايد حضرتك، محاضرة روعة وممتعة
شكرا
كالعادة.
لكم على الاستضافة، ولو في أي سؤال أو سؤالين كده مهمين، أو نقول صلى الله وسلم وبارك على نبينا محمد ونختم.
طب انا عندي اسئله عن المانجمنت اوف كومبليكيشنز في الكوندوي، يعني ده هيبقى اوت اوف سكوب ولا ممكن اسالها؟
أسأل سؤالين.
ماشي. طب بقى يعني اول سؤال، ساعات بيشنت بيجي مثلا بسيفير بالمونري جيرش اور بالمونري سنوزس ودايليتد ار في، وهو كلينيكالي فاين، ساعتها في الانتي فيلير اعتمد على كلينيكال بيكتشر ولا على الايكو بيكتشر؟
Well, is a clinically well and you really evaluated him clinically well, because when you say clinically well يمكن المريض ما بيسوي شيء، قاعد في البيت ما بيتحرك. Waiting to see signs of hepatomegaly or lower limb edema or facial edema, that's too late. وهذا المريض حيكون جاك يكون خلاص يعني خلصان. Maybe you have to look for subtle signs. Subtle signs like a JVP. كثير ننسى احنا evaluating the JVP. If the JVP suggests it's high, then even without heart failure clinically, I may start some diuretics. But the more important is that you need to evaluate this conduit more and more. Why is this so bad? Why is it so bad by echo, but clinically okay? Is it just that this is the honeymoon, you know, before the patient fails? That's why it's an anticipation. We do not wait. If echo suggests that there is severe conduit regurgitation, the RV is significantly dilated by Z-score, you immediately have to go, even without symptoms, regardless of treatment, whether you treat or you don't. You need to go to cardiac MRI and prove that this is severe, that it qualifies by criteria for a valve change, and then you go for the real therapy, which is the valve change. I wouldn't be against starting some Lasix if I see severe dilatation, severe PI. It actually may help. But then the JVP in the clinical exam will be abnormal. نعم.
شكرا، تسلم الف شكر يا بروف. معلش السؤال الثاني، حضرتك قلت سؤالين. البريفر بيت هل ليه كرايتيريا معينه لازم اتدخل في البريفر بيت؟ حضرتك قلت بريفر بيت ممكن يهارم الكوندوي نفسها، امتى البريفر بيت لازم يتعمل سوى له انترفنشن؟
البريشر جريدينت
مثلا ببريشر جدا معين، ولا على حسب الاناتومي، ولا حسب ايه الكرايتيريا للبريفر
طبعا.
بيت؟
احنا we said that the criteria في 10 criteria. اي واحد منهم abnormal, severely abnormal, you need to do something. يعني لو باي 2D انت حاطط كوندوي، مفروض الشراح قال لك انا حطيت كوندوي 14 ملي، وانت باي 2D الكوندوي هذا 6 ملي، وباي كلر 6 ملي، وباي جريدينت 40. which will you trust؟
2D وكلر
طبعا you know that this is severe regardless of the gradient. But if we talk gradient alone, يعني كل شيء تاني مظبوط. Function is good, no severe TR, no PI, no pulmonary hypertension, no PPS, just the conduit. Then it's fair enough to say if a conduit is obstructed with a gradient of around 70 peak systolic gradient, then this gradient needs something done. Whether you go and change it surgically, which is my preference in the younger child. يعني لو يجيني واحد عمره 6 8 سنوات 9 سنوات والconduit is obstructed والgradient 70, I would go for surgical, not transcatheter. احيانا we buy time, نخش مثلا نسوي بالون نخفض الجريدينت شويه او نحط ستنت واحنا عارفين ان احنا هنغيره بس عشان نحول الباثولوجي من ستينوزز الى ريجيرج، والريجيرج المريض يتحمله افضل. تمام. وبعدين نغير الكوندوي. لكن ارجع لسؤالك، اذا كل شيء تمام والجريدينت is high, yes I depend on the gradient number. 50 to 60 is moderate to severe. Above 65 is severe. My number to change the conduit and to limit our intervention if the gradient is 70 or above.
تمام يا بروف. انا كنت اقصد كمان البلمونري برانش ال بي والار بي
تمام.
امتى
So
بنتدخل؟
branch pulmonary arteries evaluation depends the same way on size, color, gradients. If size is okay, gradient, sorry, color is good, maybe it's just a focal ostial stenosis, then a gradient of 30 with good function on both doesn't mean much, صح? It's mild. A gradient of 40 to 45 is moderate. For sure, a gradient of 50 to 60 is severe. بس تعرف الأهم من الجريدينت حق البي بي اس ايش؟ ايش الأهم يا أحمد؟
الار في بريشر
يس
ولا
يس الار في بريشر. ممكن تلاقي 40 و40 بس الار في بريشر 80، صح؟
تمام
80 اكيد حيكون 2/3 سيستميك، صح؟
تمام
خلاص. فباي ذات كرايتيريا something has to be done حتى لو الجريدينت كان 40. بس ممكن تلقى 40 و40 والار في بريشر 55 then وجود function then I will not intervene، صح؟
صح تمام
في البي بي اس لازم تحطها مع الار في بريشر.
تمام.
تمام.
شكرا جزاكم الله خير.
امين جميعا. طيب، الله يجزيكم خير وشكرا جزيلا لحضوركم جميعا. تصبحون على خير ونراكم دائما على خير بإذن الله تعالى في مناسبات سعيدة، والله يحفظكم ويحفظ كل مسلم. السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.